Okay, so this is a 54-year-old female who received total hysterectomy and bilateral oophorectomy. So she had a past history of endometrial cancer, so that's why she came to our hospital for the definite surgery. So in these washing cytology specimen, so this is the peritoneum washing. For usually, if it is a benign peritoneum cells in the washing cytology, you should see more like a flattened, larger type of fragment. But here you see only very tight three-dimensional cluster. It is very easy to appreciate that these high-grade polymorphism. So for the primary endometrial cancer, this is fairly unusual to have these very high-grade, tight, three-dimensional cluster. So based on the morphology, this is highly likely that the endometrial cancer is a serous type, not the endometrioid type. So this is very like a dissemination of the disease. Apparently the peritoneum is all seeded with tumor cells. So one of these subdiaphragm smear, we can also appreciate that this is high-grade adenocarcinoma cells in the subdiaphragm smear. So the patient is relatively young. She's only 55, but endometrial cancer, I think this is a high-grade serous type, not the usual endometrioid type. So let's move to finding the aspiration. We have two very classic thyroid case. The first case, so on low power, we only see like scant, thick colloid in the background. The cellularity is high, and we can appreciate that a lot of cell fragments arranged in these abortive type of decapitated papilla and flattened like sheets. And here is more like a three-dimensional architecture suggests that this is a papilla. So just based on the low power background pattern as well as the architecture pattern, this is highly suspicious for papillary thyroid carcinoma. So here we also have a very nice arrangement of three-dimensional architecture of branching papilla. So we only need to go to higher power. Usually it's the more flattened area. Try to identify if we can see any pseudo inclusion, which is a more definite like nuclear feature. So here we do see a pseudo inclusion over here. The rest of the epithelial cells looks also atypical with these oval shape, slightly disorganization, very delicate powdering cytoplasm, and occasional groove and irregular nuclear membrane. These cytologic change is throughout the entire specimen, so every epithelial cells have these features. So this is diagnostic for papillary thyroid carcinoma. So when we want to make definite category 6 diagnosis, this is the specimen that we want to see. Typical on low power, typical on architecture pattern, as well typical in the cytologic pattern. So the second finding the aspiration of the thyroid looks very different. On low power, we do not see any colloid. Additionally, the cell cluster all looks very small and very like a scattered around the entire specimen. So this looks a little bit like starry sky. So you have these very tight small cluster of cells, and when you go to higher power, you can appreciate that these cells arranged in these micro follicular pattern composed of 10 to 15, sometimes fewer cells arranged in these like a very tight cluster. The epithelial cell do show some degree of atypia, mainly increase of the size. So the nucleus looks bigger than the ordinary follicular cells. However, the shape is still rounded. The chromatin pattern is a little bit fine, so it's in between of a ground glass or a more like an open type chromatin. Some of the cells do have a little bit like elongation. It's very scattered. You can occasionally see some grooves, but it is also very focal, very scattered. So this is typical for a RAS type nuclear feature. The arrangement is also typical for a follicular tumor. So you can see sometimes a little bit polymorphism. This is also not uncommon. So this is a very classic case of our category 4, a follicular neoplasm. So we have these two very classic examples. So this is a very good case for category 4, suspicious for follicular neoplasm. So here is another thyroid aspiration. The specimen is relatively uncommon. So in this specimen, in the background, we do not see colloid. We see some old blood, and we see some cellular debris. The cellularity is not very high, and mostly are enucleated. So in this part, you can appreciate that maybe the background shows some cystic change. However, this cell looks quite atypical. Additionally, we do have some cells with bright oranginophilic cytoplasm. So it looks like squamous cells. And the other cells with spindle shape, enucleated, all looks like necrotic degenerative squamous cells. And then we start to identify some cells to show enlarged nucleus, some with hyperchromasia. And here you have these very nice, well-preserved cluster of hyperchromatic atypical cells with a high NC ratio. So this looks like squamous cell carcinoma. So here we have nice necrotic debris with only the cell shadows. Right next to it, we have a highly hyperchromatic cell but looks very degenerative. Again, here looks like necrosis, and you can see some of these cells looks like squamous, like enucleated squamous cells. So these looks like squamous cell carcinoma. When we identify squamous cell carcinoma feature in the thyroid, we will think about the possibility of either metastasis or could it be a primary anaplastic thyroid carcinoma. So we need to go back to the clinical history. The patient does has a head and neck squamous cell carcinoma, and just based on the morphology, this is consistent with a squamous cell carcinoma metastasized from the head and neck location. It is usually more keratinized, except if it is coming from the oropharynx. Additionally, for the anaplastic thyroid carcinoma, usually we will appreciate more pronounced polymorphism. So here, I think we do have a very usual type of squamous cell carcinoma. So this is compatible with metastasis. So the clinician already reach out to confirm if this is a primary thyroid tumor or if this is more likely to be a metastasis, because the treatment strategy is completely different. So we reply that this is more compatible with a metastatic lesion. So this is a metastatic squamous cell carcinoma into the thyroid. This is fairly uncommon that we will see this type of specimen. So this is a pleural effusion specimen. Just on low power, you can appreciate a striking cell cluster in three-dimensional architecture. And although on low power it looks more like a two-cell population, but when you go to higher power, most of the individual single cells all looks very highly atypical. So basically, this is effusion with very high burden of metastatic adenocarcinoma, some in tight cluster, some in more like single cells, and the patient has recently just been proved to have lung adenocarcinoma. So we have already scanned TTF1 for this case, and which is positive. So this is compatible with like persistent of disease. So you can appreciate these bubbly cytoplasm, highly atypical nucleus, very open, like a vesicular chromatins, prominent nucleola, and you can also see mitosis over here and there. So this is compatible with adenocarcinoma, and the morphology is very common for a primary lung location here, mitosis as well. So this is adenocarcinoma. So the next specimen is coming from a urine specimen. So just on low power, we can already appreciate we do have a lot of keratinized superficial squamous cells. So this is likely, still we need to check the gender, but this is likely coming from the gynecologic tract. So indeed the patient is a female patient. And when we go to like a middle power, we can appreciate some of these very tight cluster with hyperchromasia. So here is a cluster, and here is a tight cluster, and here is also a tight cluster. And when we go to higher power, it is hyperchromatic, a little bit degenerative because of the chromatin pattern and the beading of the nuclear membrane. And this is very tight, a very tight cluster with very high NC ratio. Additionally, we can appreciate scattered area with a necrotic pattern. So you do see some cellular debris along with these keratinized like squamous cells with very high NC ratio and hyperchromasia. And here again, you can also appreciate these more small but hyperchromatic cells. So the patient just had a biopsy in the cervix, and it is confirmed to have high CO and with foci of invasion, suspicious for squamous cell carcinoma. So this urine specimen is compatible with the shading of the patient's squamous cell carcinoma. And because we do see necrosis in the background, so I think it is okay that we can like upgrade the diagnosis, but it is also okay because the patient has already been proven to have cervical lesion. So if you just say a typical squamous cell, which is also fine, but indeed these cells do looks like high CO, and we do have foci of necrosis, so it is okay that we can just call it because it's compatible with the clinical diagnosis as well. So this is a specimen involved by high CO and perhaps squamous cell carcinoma as well. So here you can appreciate these high-grade cell cluster. So let's take a look at some pap smear. So this is coming from a 53-year-old female. So just on low power, you can already appreciate the background is like kind of necrotic and dirty. We do not see nice individual superficial and squamous cells, so the background looks a little bit atrophic, but with a lot of degeneration and perhaps necrosis and with some old blood formation. So the background is highly abnormal. And when we go to higher power, and this looks like atrophic pattern with intermediate cells, but with higher NC ratio, the nucleus does not show prominent like hyperchromasia. So these are compatible with atrophic intermediate paravessel cells. So in the background, this is the main like a composition of the specimen. However, we start to appreciate that there are some like spindly, very atypical looking cells, and as well as some like necrotic type of pattern. And the atypical like cells, you can see these hyperchromatic squamous cell. We do have superficial and intermediate cells with higher NC ratio. And these atypical squamous cells were throughout the entire specimen. It is not only one smearing direction, but this is around the entire specimen. So the entire specimen looks like necrotic, looks like with tumor diastasis and with a lot of these very strange looking like spindle cell. So here is good for high CO or even squamous cell carcinoma pattern. So it is fairly reasonable that we sign out the case as squamous cell carcinoma. However, the clinician, without a definite call, he already operated the patient. So the patient already received total hysterectomy. And the cervical examination, they only see high CO. The high CO foci is very extensive. However, the smear looks like squamous cell carcinoma. So there is a discrepancy of the pap smear versus the final histology. I haven't signed out the case. So one thing is that we can still go to the histology and try to do the deeper cut to see if there is any like a minor micro-invasive foci, but sometimes it's kind of difficult because I'm not signing out the case. So I can only communicate with the sign out pathology to see if he or she want to do so. Yeah, so it's a good idea that we just wait before we sign out. So I want to sign out as SEC last week, but I think maybe I should wait. So then there's a little discrepancy between the smear and the final histology. So I think we should maybe try to do some more like examination for the final specimen. But however, if the sign out pathology is fairly comfortable to just sign it out as a high CO, maybe we should just call these as high CO. So sometimes we will have a smear looks typical for SCC, but in the histology, there is only high CO. The next smear is totally opposite, the reverse situation. So on low power, this pap smear, this is coming from a 57-year-old female. Again, you can appreciate the background. We do not see like a good, mostly like individual, superficial, intermediate cells. Instead, we do see these intermediate cells with fairly rounded shape and with some glycogen in the cytoplasm. So these are glycogen, these are not codicity change. So this is compatible with the atrophic pattern, maybe perimenopausal or atrophy. So overall, the smear looks fairly atrophic. And scatterly, very scatterly, we can see individual cells with very hyperchromatic nucleus, a little bit increase of the cytoplasm. However, the chromatin pattern again is highly degenerative. You cannot see through, you cannot find like a granularity. This is all smashed, and the nuclear membrane is a little bit beading. So this all looks a little bit like a degenerative type of hyperchromatic pattern. And this is very scattered. It is also not along any direction, but just very few, very scattered and throughout the entire pap smear. We do not have a good visualization of like cluster of these cells. It all show up like this, just like in a single cell pattern. Around it, there's no similar cells, and the chromatin pattern is totally smudged. It looks like very degenerative. So initially, the cytotech and the cyanodoctor want to call these high CO. However, this pattern is unusual for high CO because for high CO, usually we will see the smearing direction, and we won't see these very degenerative chromatin pattern. The nuclear membrane is not continuous, and the chromatin is just all smashed, and there's no granularity. So this is in between of a precursor lesion versus if this could be just like a degenerative type atypia in a background of atrophy. So it's kind of difficult to determine, but because of the pattern, it is basically throughout the specimen. It is not like in the one smearing direction, and the quality of hyperchromasia is very degenerative. And the background also show prominent atrophic pattern, and we do not see any tumor diastasis in the background. So I find it is kind of like dangerous that we just directly call these high CO. So I downgraded to the ASCUS cannot exclude high CO. But I do recognize this cell looks very atypical. It is also uncommon to see this cell in the background of atrophy. Then the patient received biopsy. He had a colposcopy biopsy. Additionally, she has a colposcopy biopsy. Additionally, she also has a DNC. So this is her colposcopy biopsy. So it looks like SCC. But we do not see these in our specimen. We only see like a very, very scattered, highly degenerative, like hyperchromatic cells. In the DNC, there were 3 blocks of these squamous cell carcinoma. They call these DNC. So I can only presume that during the smearing, the clinician might probably, when they use the specula and they try to open the vagina, they actually didn't go to the cervix. Maybe there is a prolapse or something, and there is they just didn't open it at the cervix, and they smear it in the vagina. but with some degenerative falling off, like SCC cells looks highly degenerative. So this pap smear doesn't represent what we see in the biopsy. And when they do the biopsy, they do the cervix biopsy, they actually only at the tip of the outside. And when they try to do the DNC, they are actually in the cervix. Not probably not reach the endometrial cavity yet. So there were 3 blocks. All looks like these. All these large chunk of squamous cell carcinoma, and there's a high like a discrepancy, but I can only imagine because of the original pap smear was smearing from the vagina because the clinician didn't open the spatula at the end of the cervical location. Otherwise, it would be an easy diagnosis for us if this is at the cervix and it smear the tumor, and there would be the easy SCC diagnosis for us. So there is also a discrepancy because in the pap smear we call the ascus high, which is slightly like a lower if it is not slightly. This is much lower if the final diagnosis is SCC. But apparently, this is only what we have is these highly degenerative cells. Yeah, so sometimes I would say this is not a normal screening like a scenario because the patient already had the symptoms, so she can, and the clinician probably just roughly do a smear and then just admitted the patient and do the biopsy. So sometimes we will see discrepancy. Not surprisingly, all from the same gynecologist who is doing a very bad job. And yeah, and we often have this scenario that of discrepancy, and this all by this one gynecology. That's